Good morning. প্রথমে আমি ধন্যবাদ জানাই জাহিদ ভাই এবং সোনার বাংলা ফাউন্ডেশনকে আমাকে এই সুযোগ দেওয়ার জন্য I'm very much privileged to be a part of this, and I thank Sonar Bangla what they are doing for Bangladeshi poor people, and I wish their continued success in their endeavor to help Bangladeshi people in nephrology, dialysis, and many other ventures that they are taking. I'm one of the first victim of coronavirus, COVID-19. I got infected as I'm working in the field of ICU care and pulmonary. So mid-March, I got affected by the COVID-19. So I'm going to present mostly the pulmonary side and also what happened to me along with that, my presentation. As you know, this is an airborne disease. The virus, already Dr. Kanisban gave you information of the virus. So this virus goes to the nasopharyngeal area. It stays there for a few days, and then ultimately it goes to the lungs tissue. The virus invades and replicates in the lung cells, both in the ones that produce mucus and those bearing the cilia, like that. And it affects affected cilia don't work normally, and a buildup of debris and fluid occurs, causing shortness of breath, and in some cases, pneumonia. This pneumonia is a little bit different from usual pneumonia. So initially, when it's not that severe, the virus goes, it affects the alveolar macrophage, it activates the T cell. Then as it goes to the severity, the neutrophil and the monocyte and all these cytokines and everything affects the alveoli and causes kind of an ARDS kind of picture. Only difference in this and the ARDS is most of the time when pneumonia happens, the blood supply for that affected area is diverted to the other good area of the lung. But this COVID virus, it affects from the alveoli, goes to the venous side of the lung, the vessels of the pulmonary system, and affects that so that it loses that kind of ability to divert the blood circulation from the affected area to the non-affected area. So that's one of the reasons that patient with COVID-19 infection gets very much hypoxic because of the significant shunting of the blood to the lung tissue that is already been affected by the COVID-19 virus. So as you see that it goes to the alveoli and it goes to the, it acts like an ARDS, but it also affects the surrounding blood vessel and cause severe hypoxia in this patient. So when it happened to me, I had fever, which is a common symptom. I had dry cough, which is a common symptom, and severe fatigue. Besides that, you can have headache, loss of smell, which was also happened to me. I had significant loss of smell, loss of appetite. Nasal congestion happens sometimes. I didn't have a nasal congestion, but has some sore throat, cough without much sputum. Somebody can also have some sputum, and significant shortness of breath. You also can develop muscle pain, joint pain. You can have chills, which I had significant chills, and that was one of the worst thing that I have. And I did not have nausea, but I had a couple of times vomiting. When it becomes severe in my case, I get very confused. And first 2 weeks, I don't even remember many things. I forgot what exactly the day, night, difference, and a lot of memories I forgot. That happens. I was confused. My face, my lips become lightly bluish. My wife noted that. And some people can have cough with blood. I did not have that. I had some, chest pain for first couple of days, but after that I didn't have any chest pain. But people can have a persistent chest pain, and it also decreases white blood cell, as Dr. Kanisban already explained. People can get liver disarrangement, which I had. All the LFTs was very high. People can get kidney failure. Thank God I did not develop that, but my potassium was high. I practically stayed home, and I took care of myself in my home. When I was hypoxic, when I walk, my Oxygen saturation went down to 64%. So I called in oxygen in my house, and I took oxygen, supplement oxygen all the time in my house. So these are the most common symptoms. My X-ray. So this is an X-ray. This is not my X-ray. My X-ray was worse than this. But as you see the X-ray, this thing affects mostly periphery, but it affects almost all the lobes. And I had also right lower lobe partial atelectasis when I did the X-ray. And when I look at my own X-ray, I was scared to see my own X-ray. So this is a common presentation, especially those people that affected the lung tissue. Many people don't have that, but only those people that has a lung problem, they develop this kind of X-ray picture. Some people cannot have the CT scan because of the infection risk and all these things. So you can do a bedside sonogram, which I had, and you can see when you do the sonogram, in between the ribs, when you put your transducer, you can see this B line, which is also tells you that this patient has a consolidation there. At the beginning, you have maybe lighter B line, but as the consolidation gets worse, you can have much deeper B line, and that's a diagnostic tool to with an ultrasound machine to tell that this patient has consolidation in the lung without doing the CT scan. So the CT scan also you'll have a ground glass opacities. As you see in the CT scan, the ground glass, you can have consolidation. You can have multiple area of ground glass and consolidation. So the severity can be different in different people. So this is the algorithm how you're supposed to evaluate a patient and then decide what to do, whether the patient will be admitted or not. So this is also, you have to see the difference because it's a respiratory symptom. This is a slide to see the difference between COVID-19 flu and cold and allergies. COVID-19 has more cough, fever, and breathlessness compared to any other, and body ache. So initially in the mild ARDS, you have a hypoxia and try to give supplemental oxygen, and that is the way of treating it. The current practice is to try to avoid intubation and put in mechanical ventilation. If the supplemental oxygen through nasal cannula doesn't help, then you have to go for a high flow oxygen or CPAP, BiPAP. Only time that if his oxygenation is severe, patient develop change of mental status and become multi-organ failure or hypotensive, then that patient should be in mechanical ventilator. And nowadays, initially we treated the patient as if the patient has ARDS, but as we learn more, we are trying to avoid giving high PEEP. The current recommendation is to give high tidal volume and less PEEP. And treat as if this is different than the ARDS. And there is some study done in Germany which shows that patient that has a zero PEEP with a high tidal volume did better. And also you can go. So also proning is another way of improving oxygenation. So this is another way to give better oxygenation. But the idea now is to avoid intubation as much as possible. As long as the patient mental state is good and blood pressure is good, try to avoid intubation. I myself did not take any medicine. I tried hydrochloroquine and Zithromax, but it didn't work. It is what the supportive care which works. And it takes some time to get better. It took me almost 8 weeks to come back to my normal self. Thank you so much.